CAR T-cell therapy, a critical care perspective. One of the frontiers in cancer immune therapy is chimeric antigen receptor or CAR T-cell therapy. CAR T-cells are genetically engineered T-cells that target cancer cells such as lymphoma, leukemia, and even some solid tumors. The process begins with collecting patients' own T cells via apheresis. Lentiviral vectors insert genes encoding chimeric antigen receptors into the normal T cells obtained from the patient. Chimeric antigen receptors are now expressed on surfaces of these T cells, now called CAR T cells. They are then infused into the patient's bloodstream, typically after chemotherapy, where they undergo extensive proliferation. CAR T cells now identify and target antigens like CD19, 20, ROR1, etc., expressed on malignant and other B cells and kill them. Let's now focus on critical care management of some of the common yet life-threatening toxicities. Cytokine release syndrome is the most common toxicity caused from marked elevation in serum cytokine levels. Higher CAR T-cell proliferation means better chances of tumor suppression, however, will also lead to greater severity of cytokine release syndrome. The cytokine storm can be induced by direct target cell lysis or by activation of T cells with consecutive release of cytokines like interferon gamma and tumor necrosis factor alpha. They then trigger a chain reaction due to the activation of innate immune cells like macrophages and activated T cells with further release of cytokines like interleukin 6 and interleukin 10. Median time to onset of symptoms is 2 to 3 days after infusion. The hallmark of cytokine release syndrome is fever and capillary leak. Multi-organ involvement of this syndrome can range from mild to severe organ dysfunction. Cytokine release syndrome is graded according to severity and dictates treatment. The full spectrum includes fever and mild constitutional symptoms in grade 1 to hypotension, shock requiring vasopressors, and need for mechanical ventilation in grade 4. Management depends on the grade of cytokine release syndrome. Grades 1 and 2 can be treated by vigilant supportive therapy while also carefully assessing for infection and other organ dysfunction. Patients with extensive comorbidities or advanced age, as well as patients in grade 3 and 4, need aggressive treatment to control the cytokine storm. Interleukin 6 receptor antagonist and corticosteroids are the mainstay of treatment. Tocilizumab binds both soluble as well as membrane-bound interleukin 6 receptors, hindering interleukin 6 from exerting its pro-inflammatory effects. Neurologic toxicities may occur concurrently with or following resolution of cytokine release syndrome. One suspected pathophysiology is that there is passive diffusion of cytokines across blood-brain barrier. This theory is supported by association of increased levels of interleukin 5 and 6 in neurotoxicity. CAR T cells have been detected in CSF from patients with neurotoxicity without malignant CNS disease, hence making T cell trafficking into CNS another plausible cause. CAR-TOX is a 10-point neurologic assessment tool to grade neurotoxicity. It emphasizes alterations in concentration, speech, and writing ability that are associated with CAR-related encephalopathy syndrome. Median time to onset of symptoms is 4 to 6 days after infusion. Grade 1 CRES can progress in severity, so it is important to monitor frequently using the CAR-TOX tool. Monitoring for cerebral edema, seizure prophylaxis, and supportive care is a mainstay of treatment. Patients with concomitant cytokine release syndrome can be treated using tocilizumab. It is important to remember that this drug does not cross the blood-brain barrier, hence does not mitigate the effect of interleukin 6 in the brain. It is imperative to assess intracranial pressures in grade 2 toxicity and use dexamethasone for encephalopathy till the neurotoxicity abates to a grade 1 level. Main line of management in grade 3 neurotoxicity is management of intracranial hypertension using hypertonic saline and continuous monitoring using external ventricular drain. In addition to the above treatments, use of pulse dose methylprednisone is indicated in grade 4 neurotoxicity. A subset of patients with cytokine release syndrome manifest symptoms similar to macrophage activating syndrome or hemophagocytic lymphohistiocytosis. Excess activation of CD8 T cells releases interferon gamma and in turn recruit other immune effector cells like macrophages. Cytokines such as interleukin 6, 18, and 1 released from these immune cells further stimulate the T cells. 5 of the 8 characteristics, along with elevations in interferon gamma, interleukin 10, and 6, often indicates MAS or HLH associated with cytokine release syndrome. Managing cytokine release syndrome using interleukin 6 receptor blockade and steroids, along with daily monitoring of labs like ferritin and LDH, is crucial in the first 48 hours. Etoposide for suppression of CD8 T cells and intrathecal cytarabine and steroids are considered for HLH associated with CAR T cell therapy.